next we have Florian Hodu. I don't know if I'm saying that name right, but unless Julien is presenting on his behalf, or so topic is tracking BRAF V600E persistence under MEK inhibition in histiocytosis, a B-cell enriched signal.
Hi, everyone. So how do I switch? So yeah, I'm not Florian Hodu, who lost his passport a couple days or weeks ago, and so I have the difficult task to present for him. So he's a PhD student in the Camille Bigenval lab at IGR. And so to remind you, I'm not an immunologist. Last time I did that was more than 15, 20 years ago in the setting of systemic lupus studies. So the topic is to track BRAF V600E mutation and the persistence under MEK inhibition, and you will see that there is no elimination of the mutation, but rather a redistribution into B-cell compartment. So I don't need to remind you this. Histiocytoses are characterized by inflammation and accumulation of histiocytes, which are macrophages and dendritic cells, and it's indeed a rare disease, but it can virtually affect any individuals, children, adults, at any age, and almost every tissues. So one of the most devastating aspects of this disease are neurodegenerative syndromes, which may occur after treatment for LCH, but it's also true for ECD and mixed histiocytosis, as Dr. Kufal showed us in her presentation. Probably the subset of patients, it's written here 5%, it's probably a little bit above, at least in LCH. And so one of the reasons for why this is important is the sequelae, and this is one of the two main sequelae lesions with cholangitis that is really a problem for treating the patients. So LCH and ECD are quite different disease, but with LCH, which affect mainly children and different sites of involvement usually than ECD, which mainly affect older patients, and you can see the markers are different, but they share a common physiology, pathophysiology with the MAP kinase signaling pathway, and there is evidence of finding those mutations in the hematologic progenitors and also in the PBMC with circulating myeloid finding of these mutations. Is there a way to suppress the timer from the big screen? Because some of my... Yeah, it's very annoying. Thanks very much. Don't do that again, please. Okay. So, so the clinical breakthrough was about 15 years ago, a little bit less. The BRAF inhibitor and then the MEK inhibitors that were used for treating patients, and everyone here knows about this, with the almost constant efficacy of MEK inhibitors and of BRAF inhibitors, and on the fact that when you stop the treatment, patient will eventually relapse. And so they are indeed deep responses, but the fact that after discontinuation, patient relapse, it suggests that there are mutant clones. And it's a little bit like AIDS patient, like you will have some niche and some clones that will persist somewhere. And so this is what we wanted to do in this study. So first of all, do mutant cells persist under targeted therapies? Where are they distributed across different hematologic lineages, and what drives their persistence? So we took advantage of a quite simple study, which was to analyze digital droplet PCR strategy. So in two different types of samples, bone marrow aspiration for the CD34 compartment and also PBMC. And so we used this quantification of BRAF both for the two kind of samples, and for the PBMC, we were able to sort different lymphocyte, monocyte, and DC. So one of the first element is that you can see both in the patients with bone marrow aspiration, we have 19 treatment-naive bone marrow aspiration and 8 who were treated by MEK inhibitors. And you can see there is no difference of the VAF of BRAF before and after treatment. And when you look at the PBMC from patients, you can see that there is no difference with BRAF mutation that are found across multiple hematopoietic lineage. We had some issues, or at least Florian had, with the B-cell CD19 immunostaining in this, not immunostaining, but the B-cell analysis in this study. But anyway, the mutated cells are detectable across multiple peripheral lineage. So then we used single-cell DNA analysis, tapestry, and across multiple hematopoietic lineage. And you can see here we had 7 patients, both ECD and LCH, all coming from bone marrow, and about half-half treatment naive and treated. All were BRAF, and there were frequent co-mutation and like of CH mutation. I think MAPK1 might be a mistake here, because it's very unusual to have BRAF and MAPK1. But anyways, so when you look at the cells on this UMAP, you can see all the hematopoietic stem cell, you can see the lymphoid compartment, myeloid compartment, and you can see for all the patients that when you treat the patient, you have enrichment of, you can see mutations everywhere, but you have an enrichment in monocyte when you see, yeah, there is an arrow, or yeah. You can see in the upper UMAP that the mutations are within the monocyte, but also in the B-cell compartment. And when you look at the 7 patients, you can see that the mutations are seen in every patient, regardless of the fact they are treated or not. So then we looked at the patients over time, and when you see the cross-sectional comparison of the mutation before and after treatment, you can see that BRAF persists across various lineage after treatment. And the cross-sectional analysis suggests a shift in the distribution of the mutated cell under treatment. That's what you see with this analysis here. And what is very interesting is we were able to do a longitudinal tracking of the mutation. It was only in 1 patient, and you can see that over treatment in this single patient, but it would be nice to replicate this, we can find an increase of the BRAF mutated cells within pre-B CD10 and more mature B cells in CD1C compartment. So there is at least a relative enrichment in B cell compartment, and this is clearly supported by this longitudinal study. So then we try to look at the transcriptonic level, and we did an RNA sequencing long-read analysis along in 10 patients with 6 ECD. All samples came from bone marrow, and all were BRAF mutated with frequent CH associated, and you had 6 treatment naive and 4 treated patients, and we interested ourselves in the hematopoietic stem cluster, which is, as you see here. And so there was on the analysis different reprogramming in terms of transcription among these cells, with some markers like EBF1, IGL, L1, and 2 others here that are upregulated, as you can see here, under treatment. And this is consistent with enrichment of the mutated cells in the mutated BRAF V600 mutation in B-cell compartment. So, to conclude, BRAF mutation persists in hematopoietic progenitor despite treatment, at least with treatment with MEK inhibitor. I didn't mention that we didn't have enough patients that had only BRAF inhibitors, so we have a couple patients who have dual therapy but never BRAF mutation alone. The treatment reshapes the distribution and the shift of mutation cells across lineage, and this shift is associated with B-cell-like transcriptional program in progenitors. So we are trying to do that in more patients, and we have the advantage to have many patients and who often accept bone marrow aspiration and recurrent bone marrow aspiration when we try to convince them. And also, this could be interesting for future therapeutic options and maybe targeting B-cell, maybe after MEK inhibitor or BRAF inhibitor. And with that, so this is Florian up there. And yeah, I'm happy to take any question.